Hello, everyone. My name is Sonja Stender, and I'm very happy to present you now a topic on chronic pruritus. Here are my conflicts of interest, and here is a short biography. So, I'm a professor for dermatology and neurodermatology at the University of Münster in Germany, and I'm head of the Center for Chronic Pruritus in the University Hospital Münster, and I'm a dermatologist, allergologist, phlebologist, and dermatopathologist. I have a long-standing interest in pruritus medicine, and due to this, my team and me received several grants and merits. So here's our outline today. So we first go through the definition terminology of pruritus, drive through the clinical presentation, diagnostics, to the pathophysiology, and then we end with the treatment of this burdenful symptom. These are our learning outcomes. So it's important to understand the classification and the burden for the patients, taking the routes through the diagnostics. We have to know the guideline and the use of modern treatments. So now let's start. And we start, of course, with the clinics. And here you see pruritus is a well-known symptom in dermatology. It's very frequent. It starts that dry skin can induce pruritus, that we find the symptom in many diseases such as atopic dermatitis, psoriasis, but also in autoimmune diseases. But of course, also outside dermatology, we find pruritus in many diseases. In internal medicine, for example, with chronic kidney disease, in neurology, notalgia paresthetica, for example, and also in psychiatry. So when we discuss here the pruritus, we do not discuss acute pruritus, what helps us to eliminate insects and toxic plants from the surface. It's only of short duration. We are discussing here the chronic pruritus and can define it as a symptom of diseases, and the official definition is that it lasts 6 weeks or longer. So, how do we see acute versus chronic pruritus? And the pruritus in the context of diseases may start with one disease, with multiple disease, or sometimes we do not know the underlying disease, but then we have pruritus as a symptom of these diseases. This leads to scratching, and scratching itself can induce several other diseases, such as chronic prurigo. And scratching dependent or independent, a state of chronicity may evolve, where sensitization processes in the nervous system start, and we will take a look at this later, what it means. And of course, ongoing permanent pruritus has an impact on the quality of life, produces burden, and the burden itself may worsen the pruritus. So we have double arrows here on this side, pruritus itself, but also the associated burden can impact the pruritus. So, and then finally, we sometimes have this situation that we do not find the underlying etiology, or we cured the underlying etiology, and we have the disease state of chronic pruritus, and then it's no longer acute, it has a long duration, and we have to find own treatments here for our patients. As various as the underlying etiologies might be, as prevalent pruritus is. And so it's no wonder that we find pruritus among the top 15 most frequent dermatoses, but also among top 15 of all global interdisciplinary diseases, according to the Global Burden of Disease Project. And what you see here is that the pruritus here is increasing with age. This is also a result of prevalence studies, what you can see here. So with increasing age, we have increasing numbers of patients being affected by chronic pruritus. We have some large prevalence studies from Germany pointing to a point prevalence of pruritus between 13 and 17% of the general population. And these numbers are similar to the occurrence of chronic pain in the population. Of course, we find pruritus more frequently in dermatological offices because there we find a lot of diseases which induce pruritus, just to think about atopic dermatitis and psoriasis. Yeah, as I said before, chronic pruritus is defined by the duration, 6 weeks and longer. And this is, let's say, a pragmatic clinical definition which facilitates the decision for diagnostics. So when you know your patient has pruritus 6 weeks and longer, you should take a deeper look what's going on. Why did we frame it 6 weeks? Because sometimes, very rarely, a lymphoma hides behind the symptom, and we do not want to wait very long until we start the diagnostics. But this definition does not allow any conclusion to the underlying pathophysiology. Another very old definition is that pruritus is an unpleasant sensation leading to the desire to scratch. And this definition is very true, and many dimensions hide behind that. So, unpleasant sensation, what can we say about that? Okay, we have the symptom severity, and severity is a combination of the duration, the quality of the symptom. It's sometimes not only pruritus, it's a mixture with burning and stinging. We have the intensity, and we will see later how we can assess that. And we have the cause. Sometimes it's in attacks, sometimes it's continuously. Of course, it's unpleasant, meaning it has an impairment on the quality of life, sometimes even resulting in psychogenic consequences, such as reactive depressions. And when I say sometimes, it's an underestimation. So it's about 70% of the patient that they have psychogenic consequences. Yeah, then we have the desire to scratch, and we have, of course, the secondary scratch lesions, and we have to separate this from primary skin lesions, primary dermatosis, and we have to separate those as a etiology for pruritus from other diseases and from comorbidities, which have nothing to do with pruritus. So you see, here is the complexity of a patient with chronic pruritus, and you have to consider all this dimension, and this explains why the medical care is not easy in one patient. Okay, what did we learn out of that for making a proper classification? Because the terminology before the year 2000 was very mixed. And we tried to make it very simple. We said there are patients who have a dermatosis, there are patients who show us normal skin, and then there are patients who have chronic scratch lesions. And this defines three groups of three clinical phenotypes of a patient. And the International Forum for the Study of Itch, the first and only international society, defines these three groups. And the IFC1 group are those who have a dermatosis. So primary skin lesions are dermatosis. Secondary scratch lesions may happen on these lesions, as you see here. Then we have the second group. This is pruritus on non-lesional skin. Formerly, this was pruritus xenomateria, but we do not longer want this term. And the patients start with pruritus on normal appearing skin, and secondary scratch lesions are possible, of course. And then we have the third group who have this chronic scratch lesions, such as chronic prurigo, including prurigo nodularis or lichen simplex. And here it might have been first with the dermatosis or without, but usually the patients cannot tell you. Yeah, so these are the three clinical groups, and there are frequent diseases behind that. Of course, here we have the dermatosis behind that. In this second group, we find systemic diseases, neurologic diseases, psychogenic diseases, or, and this is what we dermatologists know, invisible dermatosis, such as mastocytosis, for example, or urticaria factitia, so physical urticaria. And then we have the third group where we have to consider all these different diseases. And sometimes it's mixed, and sometimes we do not find an etiology. Yeah, so this is another table summarizing what I just said. We have here these different categories: dermatological categories, systemic, where we find chronic kidney disease, liver disease, neoplasia, and so on, but also intake of drugs. We have neurological diseases such as notalgia paresthetica. We have psychiatric and psychosomatic diseases. Yeah, let's take a look at the scratch-induced lesions. Pruritus is not always associated with scratching. And this is what we know. For example, here in urticaria, the patients rarely scratch. They don't scratch. And we do not see scratch lesions. Why is it? Because scratching is not helpful. Yeah, scratching only helps when the pathology is also in the epidermis. So when the epidermal nerve fibers are involved in itch generation, then we can scratch and remove the nerve fibers. But in urticaria, we can't. And so here we do not see the scratch lesions, but in this patient, we see scratch lesions, and we see that he cannot reach the central back with his hands. And here the scratch lesions are spared. Yeah, and because this looks like a butterfly, Jeff Bernard gave this name, and we like the name very much, the butterfly sign. Yeah, and also in children, this is very true because in children you usually cannot tell them do not scratch. So if they avoid scratching, then scratching doesn't help and even may worse pruritus. And this is a typical sign for cholestatic pruritus, in contrast to atopic dermatitis, where the children cannot stop scratching. Yeah, here taking the photography, the child could not stop scratching. Even the photographer told the child to just stand still. Yeah, patients use scratching instruments, and this gives you different phenotypes, as in this patient, where we found this lichen amyloidosis because he always uses this metal brush. And so the scratch lesions broadly vary between patients. And here you see patients with the same underlying disease. This is chronic kidney disease associated pruritus. But we have different clinics depending on the scratching behavior. And the other statement around is also true, that have you different underlying disease, you might have the same clinics. You see the butterfly sign, you see the prurigo, but the etiology for the pruritus was different in these patients. And you see the broad range between dermatosis and systemic diseases, and they have nothing in common but the itching and the scratching behavior. Yeah, and sometimes you see different scratch lesions in one and the same patient, as here, where the patient had prurigo at the lower leg and lichen simplex at the back. Yeah, what can we do for diagnostics? And here, fortunately, we have a guideline, an S2K guideline on chronic pruritus. It's published in Acta Dermatovenerologica, and it's open access, so you can get there. And here the diagnostics is thoroughly described. And of course, we need the general history, we need pruritus-specific history, we need the dermatological investigation, and then we need, maybe we don't need it, we need laboratory radiological investigations and a skin biopsy. General history is essential. Yeah, asking the patient when did it start, and when the patient tell you, yeah, it starts when I become pregnant, you already have the diagnosis. Sometimes it's as easy as that. Here are the specific diseases in pregnancy which lead to severe pruritus. We have atopic eruption of pregnancy, polymorphic eruption of pregnancy, pemphigoid gestationis, and nododermatosis, but important to know, intrahepatic cholestasis of pregnancy leading to severe pruritus on primarily normal skin. And these specific diseases in pregnancy, they add to the occurrence of pruritus in 20% of the pregnant women, next to physiological skin changes, worsening of pre-existing dermatosis, or onset of new dermatosis. And these four conditions have to be taken into account when a pregnant patient comes to you and tells you, I'm itchy. Yeah, but how to differentiate these four specific conditions in pregnancy? And the time course when it starts is interesting. So atopic eruption of pregnancy starts early, while the other three start later or even after delivery. Also, it is important to know that intrahepatic cholestasis of pregnancy and pemphigoid gestationis have a risk for the baby. So it's very important to diagnose them. And it's also good to know that both of these can start only with pruritus and no skin signs. Of course, in pemphigoid gestationis later, you have the signs, the typical signs of the dermatosis. And in intrahepatic cholestasis of pregnancy, later you might have scratch lesions up to prurigo. And prurigo may also evolve in atopic eruption of pregnancy. So it's important here to separate these two. And this is very easy because you draw fasting blood and determine the bile acids. Yeah, so pruritus specific history, we ask when did it start, where did it start, how was the cause, was there an onset with or without skin lesions, and if you had skin lesion, was it also outside the skin lesions, how long is the itching? And this is a very important question because when we have chronic pruritus on non-lesional skin, so normal appearing skin, and this is below 12 months, then we have to look for lymphoma or liver tumors. So when the patient tells you I have pruritus for 3 years, then it's the risk is low that they have a malignancy behind that. But if it's below 12 months, be careful with your patients. Contact with water, if the patient say yes, it's always after contact with water. Um, it might be related to a hematological disease such as polycythemia vera. Mechanical induced, so avoidance of scratching. We have an urticaria and cholestatic pruritus. And then we ask about the pruritus intensity and the quality of life. And these are our 7 itchy questions. So localized pruritus, sometimes very easy to diagnose when the patient tells you, I have itch only at the arms, and then you know it's maybe the dermatome C5, C6, and this is brachioradial pruritus. And then you do a radiological investigation, magnetic resonance imaging, and you see here some vertebral abnormalities. And when it compresses here, in the sensory area, you know this is the origin of your pruritus. So why do we have here number 6 and 7? Because this is important for monitoring your treatment. And when the patient returns, you always ask for number 6 and 7. So how is the pruritus intensity and is your quality of life impaired? And for number 7, you know that there are questionnaires we can easily administer in our private office. Yeah, but how do we assess pruritus? And here are the most used 3 instruments. We have here the visual analog scale, which is just a line from no itch to worst imaginable itch. And these are the only 2 anchors. And then the patient makes a cross here somewhere on the line. And then you can measure from here what is 0 to here 10 or 100. And you have exact numbers for your itch intensity. From 0 to 10 acts also the numeric rating scale, where we ask for full numbers. And this is sometimes easier for the patients, that they give you a full number and you can ask this orally, while the visual analog scale is always on paper or on tablets. And then we have the verbal rating scale from no itch to severe itch. Yeah, it's just a very simple grading that you can ask your patient, how is your itching? It's very severe or moderate, but then it's his own definition. While for the visual analog scale and numeric rating scale, we have some cutoff values. Yeah, so we know what it means. The severe itch, it's 7, between 7 and 9, and very severe is 9 to 10. Below that, we have moderate and mild itching. So what are you asking for? And it's becoming more and more clear that we ask here at the numeric rating scale for the worst itching in the past 24 hours. You can also ask about the average itching, but there is the risk that the patient tell you it's 5. Yeah, because when you say average, the patients think about 5 as a typical value for that. Yeah, then it's the question, okay, I have a pruritus patient who tells me it's a 7, but where do I have to go with the patient? Do I have absolutely to go to 0, or what is a clinical important reduction? And here we have some studies on this. First, we have the minimal clinical important difference. And this study were done in Poland and in Germany around the VAS and the NRS, asked for the maximum and the average, and the numbers were all similar. Here we have to have a reduction between 2 and 3, that we have something what the patient experience, that there is a drop of the itch intensity. And from atopic dermatitis studies and psoriasis studies, we know that a 4-point reduction is clinically meaningful. So this is really a dramatic and significant reduction. So if you want to bring your patient significantly down in the itch intensity, you have to achieve a drop of 4 points. And this is, for example, also a responder criteria in many of the currently ongoing clinical trials, a drop of 4 points on the NRS. Yeah, we come back to the guideline, and here is a table, a very nice table where you can take a look on the diseases which might induce pruritus, and we find a long list of diseases. And of course, we need something like that, an algorithm driving us through the diagnostics. And yeah, this is a little bit complicated, but what you see here is we have a very straightforward way. When we see a dermatosis on the skin, we all know what to do. Here at the bottom, taking skin biopsies or lab and so on. And here the other area, the other side, we have patients who have no skin lesions. And here we have a very detailed algorithm which really helps you guiding your diagnostics. So do we have an elderly patient, or do we have a potentially pregnant woman? And if this is all not true, can we find something? Can we detect something for internal disease? So at this moment, you are doing the laboratory analysis. And when we're here in the middle, when we have patients with chronic prurigo or lichen simplex, we have to consider both underlying dermatosis, underlying internal diseases, or psychiatric diseases. So this is then really helpful to have such a guidance to the diagnostics. Yeah, and here is a brief summary. If you have a dermatosis, you do your daily business. If you have patients with pruritus on non-lesional skin, we have to do primarily laboratory and radiological diagnostics. Think about brachioradial pruritus, then you know why we have to do radiological diagnostics. And this is the most complex situation where we have chronic prurigo and we have to look for the underlying diseases, which might be everything. Yeah, the diagnostics, what are we doing then when we say we're doing laboratory diagnostics? Of course, we're doing this step by step based on the history, of course, age, comorbidities, etc. And here you find in this nice table out of the guideline, you find detailed recommendations what to do. For example, don't forget ferritin. And this is in fact something what our GPs and internal med specialists see very frequently in young women when they come with generalized itching. Sometimes it's iron deficiency, anemia, and then it's very easy to treat them. Yeah, also there is a long list and even more in the guideline for further investigations. And here we have also a detailed approach for what are we asking in addition for the medical history. We have one important recommendation for you when you have a patient and you do not know what is the underlying etiology for chronic pruritus. You should repeat every year the diagnostics, because sometimes we have premonitory pruritus and the disease starts later. This is, for example, typically in polycythemia vera. Years before you can detect it, the patients report already pruritus, and it's not always aquagenic pruritus. So it's worth doing a small, simple diagnostics and repeat it every year in these patients. Yeah, now we come to what is known about the pathophysiology, which roots are known in the central and peripheral nervous system for pruritus transmission. So we start, of course, in the skin, and we know that here all structures and cells might be involved in the generation of pruritus. And the most advanced research is in the field of atopic dermatitis. So here you see a graphic summarizing what's known in atopic dermatitis. And I'm sure you know this graphic. So we have here the Th2 cells in the middle, and they release, for example, interleukin 31. And this is the pruritus interleukin. It binds to receptors which are on the nerve fibers and directly induces pruritus. It attracts more inflammatory cell. It contributes to establishment of fibrosis in the tissue or worsening the epidermal barrier. So all other mechanisms which might enhance pruritus. Interleukin 4 and interleukin 13 are also pruritogens, and they are also released by Th2, and they might also bind to the nerve fibers directly to induce pruritus. But also mediators coming from keratinocytes released by keratinocytes such as TSLP also binds to the nerve fibers, also directly induces pruritus. So you see we have here many possibilities of itch induction in atopic dermatitis. What is here on the other side is a mast cell. And of course, the mast cell also releases histamine, and this, of course, binds also to nerve fibers. And we will take a look why this is not so relevant in atopic dermatitis, and we don't have an arrow here from histamine to the nerve fibers. Yeah, what is very interesting is the work from Brian Kim's lab. He detected that interleukin 4, by binding to its receptor, the interleukin 4 receptor, is an important yeah, inductor of chronic pruritus, because this pathway, when it's continuously activated, sensitizes the nerve fiber. So the threshold is going down, less substance is needed to activate the cells, and also other interleukins, which are then in the tissue, might more easily induce pruritus. And this is a very important step in the chronicity, what I showed you at the beginning, that we have the sensitization of the nerve fibers. Yeah, and this is an important part of that. Yeah, here are our nerve fibers, and we know now that we have different C and A fiber classes in the skin and in the epidermis. And the different C fiber classes are defined by their receptor expression and by their functionality. And for example, 5% of our skin nerves are pure histaminergic. They have the H1 receptor and they do almost only respond to histamine and nothing else. And it's now better understandable that when we only target 5% of the nerve fibers and we have all these interleukins in the vicinity, that the clinical impact of blocking antihistamine receptors is not so huge, and that the antihistamines have not this yeah, high clinical effect on patients with chronic pruritus. Yeah, and this graphic summarizes the current knowledge. So we started 20 years ago by identification of the histamine fibers, yeah, and we thought, okay, now we have fibers which are for itch transmission, and we can separate the fibers which are for pain transmission, the so-called C fibers, which respond to mechanical and heat stimuli. But 10 years later, it was demonstrated that these CMH fibers can also transmit itching. They have also special receptors like the PAR2 receptor or CYP1 receptor, which may help in the generation of itching. And also in between now, the R delta fibers have been demonstrated that they can transmit itch. So these fibers are usually or were originally described for their generation of pain, but they can also sense itching. So we know that many fibers of the skin can generate itch signals. And here you see a little circuit in the skin, because this is what I told you. We have the inflammatory cells, especially T cells. They release interleukins, they activate the nerve fibers, but activated nerve fibers themselves release neuropeptides, and we have many in the nerve fibers, and they have efferent functions, meaning they bind to the vessels, attract inflammatory cells coming to the tissue, and they may then release again interleukins, and other substances. So here we have a little circuit, and this explains that upon scratching, when we have activation of the nerve fibers, we have a promotion of inflammation. Yeah, so now we travel outside the skin. Here are our skin fibers, and they are here bundled in the peripheral nerves. They run over the dorsal root ganglion, where we have the cell bodies, to the dorsal horn of the spinal cord. The end here, second neuron starts, crosses the site, and travels then here via different pathways to thalamus, somatosensory area, and to the cerebellum. An important area where we can also interfere with our treatments is the communication between the first and second neuron, or to make it more complex, to our interneuron connections. So here we are in the skin, we have our different fiber classes. We are here in the dorsal root ganglion where we have the cell bodies, and then you see we have here a crowd of interneurons, of connections before everything goes here to the brain. And this knowledge is, of course, not complete, and it is, of course, not representative for humans. This knowledge is gained from animal studies. But what we know is for sure that here the pain fibers have at some location control over the itch processing, because this is what we are doing when we're scratching. We are activating this axis, and then the signals cannot travel to the brain. But what we also know is, for example, here that we have a release of kappa opioids, and they hinder the transmission to the brain. And this is something what is at the moment also in pharmaceutical development to control chronic pruritus. Yeah, to summarize here our pathophysiology, this was a very brief insight into that. We could discuss this much longer, but we have important steps in the chronicity from acute to chronic pruritus, and this is functional sensitization. I showed this for the skin. I showed you the interleukin 4 effect. This refers to cutaneous nerve fibers, but this is also true for peripheral nerve fibers and the central nervous system, that we have there functional sensitization. And it's not only due to interleukins, but also due to scratching. And this was demonstrated by the working group of Gil Josipovic from Miami. We also have a lot of structural changes. What we see clinically also, scratch lesions. Yeah, they gave a different anatomy to the skin. We have injured epidermal nerve fibers. We have reactive thickened dermal nerve fibers, and we have increased expression of receptors and neuropeptides. So let's talk about the burden of chronic pruritus, coming back to the clinics. And one instrument to assess impairment of quality of life is the Dermatology Life Quality Index. And this was done here in over 500 patients. You see analyzed by the DLQI bands, meaning no effect, small, moderate, very large, and extremely large effect on the quality of life. You see that the itch intensity nicely correlates in the whole population of patients, but you see here also in the range that in individual patients it must not be true. Some have high intensive itch but do not suffer, and vice versa. Some have low intensive itching, but they suffer a lot. Yeah, the other analysis around is also true. Here analyze over 1,100 patients with chronic pruritus, and here analyze for the bands, the visual analog scale for weak, moderate, severe, and very severe pruritus. And you see again here that the DLQI numbers are increasing. So this association seems to be true. But what influences the burden or the impairment of the quality of life next to the intensity? And so we analyzed the patients by the group. And here you see that the patients with IFSI group 1, so dermatosis, or 3 chronic scratch lesions, have higher impairment of the quality of life compared to patients who do not have any skin lesions. Women are higher impaired than men. but the pruritus intensity had a much higher impact on the quality of life than the clinical group or the gender. So this is really true that the higher the itch intensity, the more burdened are the patient. Another analysis asks for the willingness to pay. And this is interesting because patients with chronic pruritus are willing to trade up 1.2 years of future decade to obtain 8.8 years of perfect health. And this is a lot. And they are also willing to pay a lot to get a perfect treatment. So this also reflects the burden in the patients. When we coming now closer to the treatment, and we have to ask ourselves first, what are the patient needs? Of course, we assume that they want that the itch is controlled, and this was checked by this analysis in over 1,500 patients by using the patient benefit index, an instrument developed by Matthias Augustin from Hamburg. And here you see the top 5 needs. And surprisingly, control of itch was only number 2 in the aims. Number 1 was find a clear diagnosis and therapy. And number 3, have confidence in the therapy. So here we have a clear need of the patients pointing to the medical care. And we see that still we do not have a global agreement and harmonization how to treat these patients. And you see the way we have in front of us to do that. Yeah, but when we're thinking about the treatment, how can we treat the patient? Is it enough to find and treat the underlying condition? From that, what I said already, it is not sufficient enough. What can we do to treat the sensitization? Do we have approved drugs? And what are the current trials? And from the comment on the histaminergic nerves, that histamines do not work so much and that we are near to the end of the histamine area. I mean, every one of us is using antihistamines, but they are not so effective as we all know. And this was also documented in a systematic review. This was addressed around the indication of eczema, pointing mostly to atopic dermatitis. 25 studies were found, and the authors concluded that there's really no evidence that H1 antihistamines are more effective than other treatments for eczema. Yeah, what is the current alternative that we can use? And fortunately, we have guidelines. We have the already mentioned European guidelines. We have a German guidelines, and I present you now the recommendations from the European guideline. And what are your treatment steps? So we start with general measures. We explain that patients should use emollients. Maybe we start with antihistamines, eventually in higher dosage. The advantage is that we have few side effects, that we start slowly. We can recommend or prescribe that. Then we go to the next step. This is a symptomatic treatment adapted to the etiology of pruritus. So there are studies, for example, for cholestatic pruritus. And when we identify that, we can treat them with rifampicin or anything else according to the guidelines. Here, we have to be careful concerning the side effects, of course, but also we have the issue around off-label treatment. And if this does not help, or if we do not find the underlying etiology, we have to consider using treatments where we know generally it hinders the transmission of the signals from the periphery to the brain, like the gabapentinoids, for example. Again, here we have to consider side effects. Of course, we are here now in the off-label area, or we can invite patients to participate in clinical trials. Yeah, what are the substances which are currently recommended in the guideline? So on the one hand, we have a lot of anti-inflammatory substances where we know they nicely can control the itching. For example, UV treatment, systemic glucocorticosteroids, cyclosporin A, methotrexate, and thalidomide is also here on the list. Though I have to say, in Europe, we do not feel so comfortable using it because of the potential side effects. On the other hand, we have substances which interfere with the transmission of the signal from the skin or the peripheral nerve to the brain. And this is, for example, the gabapentinoids, opioid modulators, or antidepressants. And we have here also some topicals we can use. Capsaicin destroys peripheral nerves and they can regrow when they have been destroyed before, and calcineurin inhibitors also target the nerve fibers, the peripheral. So, what to say about the gabapentinoids? And the guideline recommends them in neuropathic pruritus and chronic kidney disease associated pruritus, and suggests the gabapentinoids for refractory chronic pruritus and pruritus of unknown origin. So a very broad recommendation due to the very good experience the experts of the guideline make with the substance. There are several case series, single randomized controlled studies, especially in chronic kidney disease associated pruritus, where they really work very nice. Here is to say that you should maintain the treatment with gabapentinoids for at least 8 to 12 weeks before you make a decision. And if you have to discontinue the substances, you have to taper off them within a week. Here is an example from our center, a patient with prurigo before and 2 months after initiation of pregabalin. Opioid receptor antagonists, and this is naltrexone or nalmefene or naloxone. And this is suggested in refractory chronic pruritus and in cholestatic pruritus. And we have some randomized controlled trials for cholestatic pruritus. Intravenous naloxone is better tolerated as naltrexone peros, but of course, intravenous naloxone is a little bit more difficult to administer, especially as you have to administer it over 8 hours. And we do it regular when we have patients inpatients, but this is not possible in all countries. Yeah, here is a patient who has severe chronic prurigo and atopic predisposition, and we treated her with almost everything, also cyclosporin, but this was not helpful, and so we decided to give her naloxone 10 cycles plus 5 cycles systemic steroid, and here you see that the result was good, even though she did not heal completely, but we are still making the treatment for this patient. Yeah, what about the opioid modulators, the kappa opioid receptor agonist? I told you that there is kappa agonist release in the spinal cord, and accordingly there is now a pharmaceutical development. So for example, we have nalbuphine, who is a combined kappa agonist mu antagonist in oral form, what is of course very comfortable for the patient, and this is now in chronic nodular prurigo indication in phase 3 study. Another substance for intravenous application, difelikefalin, performed already very nicely in phase 2 and phase 3 studies. And here you see the responder analysis. Now we have here the responder analysis of 3 points. I told you before that in dermatosis we have 4 points as a responder, and here we have 3 points. Worst itch responder analysis, and you see a very nice cause here that many of the patients receiving the substance had a good pruritus control. What about antidepressants? And they work in pruritus as well as they do in pain. As a monotherapy, it's a little bit difficult to apply them and to achieve a full remission of itch, but we usually combine them together with gabapentinoids, and then they work very nice. The guideline says, or the guideline recommends antidepressants, and here you see which one they suggest for psychogenic chronic pruritus and refractory chronic pruritus, especially in malignant cholestatic and chronic kidney disease. And here we have some randomized controlled studies, for example, for paroxetine or sertraline. And they work also in non-depressed patients. There's one analysis demonstrating that in non-depressed patients for control of itching. Yeah, where are we going in pruritus therapies? To summarize here, we identified already the problem of the neuronal sensitization. And what is, of course, important now is that we prevent that neuronal sensitization. So when the patients start to itch, we have to offer early a treatment to really hinder the nerve fibers to generate the itch every day and to become sensitized. The pathophysiology we understand better, and there are already some targets identified, so that the pharmaceutical develop is currently in progress. And this is a very fortunate situation for our patient. And by having said that, we terminate now our journey through chronic pruritus, and I thank you very much for your attention.